Imagine your life just completely falls apart. You lose your job, your marriage ends, and maybe, I don't know, you're forced to pack up and move across the country, all in the exact same month.
Yeah, a total nightmare scenario.
Right. You can barely get out of bed, your stomach is constantly in knots, and you are just suffering deeply.
Because of course your whole world just shifted.
Exactly.
Ah.
But if you walk into a psychiatrist's office today to get help, there's a very good chance they will look at your devastated life and diagnose you with something that is arguably the most controversial, unstable, and hotly debated category in modern medicine.
Yeah, that scenario puts you right in the middle of this massive psychiatric battlefield. I mean, most people, and honestly, even many doctors, they assume the diagnosis we are talking about today is just simple, standard, practically uncontroversial.
But it's really not.
It is anything but simple, yeah.
And that is exactly what we're unraveling in today's deep dive. We are exploring the incredibly messy world of adjustment disorders.
It's such a fascinating topic.
It really is. We're looking at that invisible line where a normal, deeply human struggle with change actually crosses over into a medical diagnosis. And to do this, we have a phenomenal stack of sources on the table for you today.
We really do.
We are pulling from Eric Lindemann's 1944 Coconut Grove study, the famous Holmes-Ross Social Readjustment Rating Scale, deep histories of the American and International Diagnostic Manuals, Mitchell's 2011 Lancet Oncology meta-analysis, and journalist Joshua Core's explosive military discharge reporting.
And, the through line connecting all of those sources is this fundamental tension in psychiatry.
Right.
It's the desperate need to objectively measure something that is inherently subjective human grief and resilience.
So let's start with the rules of the game, according to the American medical system, specifically the DSM-5.
Right, the diagnostic manual sitting on practically every psychiatrist's desk in the United States.
Exactly. According to the manual, an adjustment disorder occurs when you develop emotional or behavioral symptoms like anxiety, low mood, or sudden conduct problems in response to an identifiable stressor.
But they don't just leave it open-ended.
No, they don't. They put this strict stopwatch on your suffering. Your symptoms must begin within 3 months of the stressor, and once that stressor ends, your symptoms have to resolve within 6 months.
Which sounds incredibly rigid, I know. But the clinical necessity for those boundaries comes from a desire to separate a temporary reaction from a lifelong chronic illness.
Okay, I hear that.
Right, because if someone is suffering for a year after a discrete event ends, the manual wants clinicians to pivot. They want them to start looking at major depressive disorder or generalized anxiety.
So it's about categorizing the duration.
Yeah, and this impulse to, time box human distress actually traces back to one of our sources, Eric Lindemann's classic 1944 study of the Coconut Grove nightclub fire in Boston.
That fire was an absolute tragedy. I mean, nearly 500 people died.
Yeah.
And Lindemann was studying the survivors and the family members of the victims, right?
He was, yeah. And by closely observing these grieving individuals, Lindemann documented that acute grief isn't just this vague feeling.
Mm-hmm.
It has predictable physiological symptoms, tightness in the throat, shortness of breath, loss of appetite.
Real physical reactions.
Exactly. But more importantly for psychiatry, he suggested that this acute, overwhelming phase of grief has a somewhat predictable time frame.
Ah, okay.
Yeah, the psychiatric community took that foundational idea that reactions to trauma have a standard biological timeline and eventually codified it into the strict 3 to 6 month stopwatch we see in the DSM-5 today.
I mean, I understand the historical precedent there, but applying a strict timeline to everyday life transitions just feels like a rigid retail return policy on grief.
A return policy, I like that.
Think about it. It's like, sorry, sir, you're on day 181 since your divorce was finalized. We can no longer accept this sadness as an adjustment disorder.
Right, the window has closed.
Yeah. Real life rarely fits into a tidy calendar. You don't wake up on month 7 and suddenly feel your grief evolve into major depressive disorder.
Yeah.
You just feel like you are still having a terribly hard time coping.
Exactly. The timeline creates this false sense of scientific precision around a remarkably messy human process.
Seriously.
And if mapping the timeline of distress proved complicated, well, historically, psychiatry's attempt to objectively measure the triggers, the stressors themselves, was just as fraught.
Oh, man. Which perfectly tees up the Holmes-Ross Social Readjustment Rating Scale from 1967.
Yes.
So psychiatrists Thomas Holmes and Richard Rye decided they were going to quantify human stress. They examined thousands of medical records to see what life events preceded illness, and they assigned a literal point value to different life changes.
They essentially created a mathematical formula for suffering.
It's so wild to me. The death of a spouse was the baseline, right? Anchoring the scale at 100 points.
Right, that was the maximum single stressor.
And then a divorce was worth 73 points. Getting fired was 47 points.
Even good things had points.
Yes. Getting married was 50 points because, it requires profound adjustment. A traffic ticket was 11 points.
A traffic ticket.
I know. And if your total score over a year crossed 300 points, they claimed you had a significantly higher statistical risk of a major health breakdown.
But the mechanical flaw of the Holmes-Rahe scale is immediately apparent when you think about individual psychology.
Oh, for sure.
I mean, it assumes a 73-point divorce impacts a financially independent person with a strong support network the exact same way it impacts someone who is completely isolated.
Right, which makes no sense.
It treats human beings like standardized machines, where a specific input automatically equals a specific output of stress.
Which brings us back to the core controversy of the DSM-5 criteria today. If the timeline and the point values try to be objective, the actual symptom requirement in the American manual throws all that objectivity right out the window.
Yeah, this is where it gets really murky.
Because to diagnose an adjustment disorder, a doctor must determine that your distress is, quote, out of proportion to the severity or intensity of the stressor. Or it must significantly impair your functioning at work or in relationships.
That phrase, out of proportion, is the hinge upon which this entire debate swings.
Out of proportion.
It forces the clinician to play the role of philosopher and judge.
Let's use a concrete scenario.
Yeah.
Imagine a 40-year-old patient. They are newly divorced. Let's say it was a 73-point stressor on that old scale, and they just lost their job, another 47 points.
A really bad month.
Right. They are sitting in a doctor's office, absolutely devastated, crying, unable to sleep. How can one doctor look at that person and say, yes, this level of crying is a proportionate normal reaction to your life falling apart? While another doctor looks at the exact same patient and says, no, this distress is out of proportion, you have a psychiatric disorder.
Well, the judgment call relies entirely on the doctor's internal baseline of what constitutes a normal human reaction.
Which is completely subjective.
Completely. That baseline is invisibly filtered through the clinician's own cultural background, their personal resilience, and their societal biases about how people should behave when facing adversity.
Wow. And because it is so subjective, the medical community frequently uses adjustment disorder as a catch-all.
They do, yeah.
Critics call it a wastebasket or subthreshold diagnosis.
Right, the wastebasket.
It's the label clinicians use when a patient is clearly suffering and functioning poorly, but they don't cleanly check enough boxes to qualify for major depression or generalized anxiety. The doctor knows the patient needs help, and, in the American healthcare system, you usually need a diagnostic code to get insurance to cover therapy.
Oh, absolutely. The billing code is everything.
So they just drop the patient's suffering into the adjustment disorder folder.
And the sheer scale of how often this wastebasket label is used becomes so clear when you look at specialized medical settings. We can look at Alex Mitchell's 2011 meta-analysis published in Lancet Oncology, which examines psychiatric diagnoses among cancer patients.
This study is staggering. They looked at data from thousands of cancer patients in palliative care and oncological settings. And the single most common psychiatric diagnosis given to people battling cancer wasn't major depression.
Yep.
It was adjustment disorder.
Which is wild, right? But the mechanism behind that statistic reviews exactly how the diagnosis functions in practice.
How so?
Well, an oncologist sees a patient who is profoundly distressed, which makes perfect sense they have cancer. The doctor doesn't want to pathologize the patient with a label of major depressive disorder because the sadness is entirely contextual.
That makes sense. You wouldn't want to say their brain is broken when they're just dealing with a horrible diagnosis.
Right, but the patient still needs psychological support, maybe medication or some sort of intervention.
So they need the code.
Exactly. Adjustment disorder becomes the bureaucratic bridge to get them that care. It acknowledges the suffering without claiming the patient's underlying brain chemistry is fundamentally broken.
It really makes you wonder how modern psychiatry ended up with such a subjective, shape-shifting category right in the middle of its main manual.
The history of the terminology itself is a fascinating journey.
It really is.
Yeah.
It shows that psychiatric labels are not handed down on stone tablets. They evolve based on the prevailing philosophies of the era.
Absolutely.
If we rewind to 1952, the very first DSM, they didn't even call it an adjustment disorder. They called it transient situational personality disorder.
Which is quite a mouthful. And that lengthy title was heavily influenced by a highly prominent psychiatrist named Adolf Meyer. He championed a psychobiological approach to medicine.
And Meyer's philosophy was actually quite holistic for the time. He didn't view psychiatric symptoms as, like, alien bugs that a person caught.
Right, it wasn't an infection.
Instead, he saw the mind and body as a dynamic organism reacting to its environment. If you were reacting terribly to a life event, he viewed it as your biological and psychological makeup, your personality struggling to adapt to a situation, hence situational personality disorder.
But placing the word personality in the diagnosis placed a subtle locus of blame on the individual's character structure.
Oh, I see. Like your personality is the problem.
Exactly. And as clinical theory evolved, the field wanted to step away from implying the patient's core personality was flawed. So in 1968, the DSM-2 shortened the diagnosis to transient situational disturbance.
That linguistic shift changed the entire framing. A disturbance feels like a passing storm.
Yes, much less permanent.
It frames the issue as a temporary disruption caused by external forces, rather than an inherent weakness in the person. And then, in 1980, the DSM-3 was published.
The big checklist era.
Right. This was the era where psychiatry desperately wanted to become more empirical and checklist-based, moving away from Freudian psychoanalysis. And that is when they adopted the phrase we use today, adjustment disorder.
And you can see how the evolution from a personality disorder to a disturbance to an adjustment disorder proves that words really construct the clinical reality a doctor sees.
They really do.
An adjustment disorder focuses the clinical lens entirely on the process of adaptation. It suggests the patient is simply struggling to calibrate to a new normal.
But does changing the name actually change how a doctor views the patient sitting in front of them?
That is the big question.
Because the danger of subjective wording goes far beyond academic philosophy. The label a doctor chooses can have devastating, life-altering consequences.
Yes.
This brings us to journalist Joshua Coors and his explosive reporting on military discharges. And this completely blew my mind.
It's a very heavy topic. Coors uncovered a systemic practice within the United States military involving soldiers returning from combat tours in Iraq and Afghanistan.
Right, so soldiers were coming home with severe trauma, flashbacks, and an inability to reintegrate into civilian life.
The classic signs of trauma.
But instead of diagnosing these veterans with post-traumatic stress disorder, PTSD Corps reported that military commanders and clinicians were discharging thousands of them with the diagnosis of adjustment disorder.
And the financial and legal mechanism behind that diagnostic choice is just chilling.
It really is.
PTSD is recognized as a service-connected injury. If you are discharged with PTSD, the military is obligated to provide you with lifetime disability benefits and medical care.
But adjustment disorder is different.
Very different. It's often classified by the military as a pre-existing condition, a temporary failure to cope, or a personality quirk that just happened to reveal itself during service.
Oh, wow. So by slapping the adjustment disorder label on a wounded soldier, the military could legally discharge them without paying a dime in disability benefits or offering long-term medical care.
Exactly. Coors reporting showed how the subjective, wastebasket nature of this diagnosis was literally weaponized to save the government billions of dollars at the expense of veterans' lives.
That is horrible. And just to be clear to you listening, we're simply reporting on what the source material from Coors investigation uncovered here, not endorsing any political viewpoint.
Right.
But it is just a stark example of how these labels function in the real world.
It perfectly illustrates why relying on a vague, out-of-proportion standard is so dangerous. When the diagnostic criteria are that loose, the diagnosis can be molded to serve the needs of the institution, whether that's an insurance company or the military, rather than the needs of the patient.
And because the American system refused to let go of this subjective standard, international researchers finally reached a breaking point.
They had enough.
They realized that a diagnosis defined by out-of-proportion distress was fundamentally useless for rigorous science. You cannot systematically test a therapy or a drug in clinical trials if the definition of the disease is just reacting more than the doctor thinks you should.
Right, you can't measure that. And this frustration led to a massive international rebellion orchestrated by the World Health Organization.
The WHO.
Yeah. When the WHO finalized the 11th edition of the International Classification of Diseases, the ICD-11, which went into effect globally in 2022, they didn't just tweak the definition of adjustment disorder.
No, they didn't.
A team led by psychologist Andreas Merker in Zurich rewrote it entirely from scratch.
Looking at Merker's new criteria, they threw out the subjective judgment call entirely. To get an adjustment disorder diagnosis under the new international rules, a patient must exhibit two highly specific, measurable symptom clusters.
Measurable being the key word there.
Right. The first cluster is a preoccupation with the stressor. This isn't just feeling sad about a divorce. This sounds like the brain has been actively hijacked. We are talking about excessive rumination, intrusive thoughts, the constant replaying of the event.
Mechanically, what you are seeing there is the brain's default mode network getting stuck in a closed loop.
A closed loop.
Yeah, the mind is trying to problem solve a past event that is fundamentally unsolvable. So the patient is no longer just experiencing an emotion, their cognitive machinery is misfiring, trapping them in a constant state of high alert worry.
And that is something a doctor can actually measure. A patient can report if they're having intrusive thoughts.
Exactly.
Now, the second mandatory cluster in the ICD-11 is a failure to adapt.
And this cluster focuses on functional paralysis. The psychological mechanism here is often allostatic overload.
Allostatic overload.
Yeah, so your body and mind's stress response has been running so hot for so long that the system just burns out.
Like an engine redlining.
Basically, yeah. The person cannot perform at work, they withdraw entirely from social relationships, and they fail to manage basic daily tasks. The natural human process of adaptation hasn't just slowed down, it has completely derailed.
So under these new international rules, it is not enough to just be profoundly sad after a life-altering event. You must be obsessively, cognitively preoccupied with it, and you must be actively failing to function in your daily life.
Right. And the practical implication of the shift is monumental. We now have a situation where the world's two major diagnostic systems are fundamentally misaligned on how to categorize human suffering.
It's kind of crazy to think about. A patient sitting in a clinic in New York could easily be diagnosed with an adjustment disorder under the DSM-5 because their doctor intuitively feels their grief is out of proportion. But if that exact same patient with the exact same symptoms walked into a clinic in Zurich or London using the ICD-11, they could be completely rejected for the diagnosis because they are still managing to drag themselves to work, meaning they don't meet the strict failure to adapt criteria.
It is a rare, rare case where the global medical community cannot agree on what a disease actually is.
It's astounding.
It forces us to recognize a massive fracture in how we view mental health. I mean, the American framework leans on a subjective timeline and the intuition of the clinician, while the international framework demands rigid, observable symptom clusters.
So to bring this all together for you, if you are going through a massive life transition right now, whether that's a breakup, a career change, or a cross-country move, and you feel utterly overwhelmed, it is vital to know that the medical community is actively wrestling with how to validate your struggle.
And really are.
The debates happening in psychiatric boardrooms aren't just academic exercises. They dictate who gets treatment, who gets insurance coverage, and who gets told their suffering is a medical condition versus just a difficult chapter of life.
And as we continue to map the human brain, we are left with a fascinating horizon to consider.
What's that?
Well, we know that the current methods of diagnosing an adjustment disorder rely heavily on observation and clinical interviews, right?
Yeah, sitting and talking with a doctor.
But as technology advances, will we eventually develop neuroimaging, AI, or specific biological markers that can scan a brain and definitively mathematically tell us if a person's grief is biologically out of proportion to a stressor?
Wow, just scanning for grief.
Exactly. Or will we discover that the human experience of loss and adaptation is so deeply personal that it will always defy computation?